Hi everyone, this is Dan with ThoroughCare. CMS published the final rule for the physician fee schedule for what to expect in 2023. I recently sat down with Carrie Nixon of Nixon Gwilt Law to talk about all the changes that will be coming as part of the 2023 final rule. In this video, we'll talk about how the 2023 final rule created a new program called Chronic Pain Management, or CPM. Chronic pain management. So this one is brand new for 2023. And the concept of it, managing patients experiencing pain, that's not a new thing. You've been doing that for a long time, and most providers do. But this would create a new type of pain model that can include some of the following elements: diagnosing that pain, assessing and monitoring it, using any type of validated pain rating tool, implementing care plans that include strength, goals, clinical needs, outcomes, overall treatment management, coordinating care, necessary behavioral health treatment. So I'm not going to read everything, but these are all the things that CMS actually lists in the regs here. There is one requirement. You can see it at the bottom. Patients must experience persistent or recurrent pain lasting longer than 3 months. So they have to have at least a 3-month history of pain in order to do this program here. And there are 2 new HCPCS codes, or G codes as they're often referred to, and they pay around $79 for the first one, G3002, and G3003 pays around $29. And we actually, it's hard to explain, so we put the actual text from CMS in here, but Carrie, I highlighted some of the things in red that I think are going to stand out to people. That first code's 30 minutes, and it says required initial face-to-face visit. So the initial 30 minutes face-to-face provided by a physician or provider. So that can be a tight restriction. Carrie, you want to talk about that one for a second?
Yeah, and it's even tighter than it may appear on its face, because they mention in the rule that in this case, when they say initial face-to-face, they mean in person in a clinical setting.
So no telehealth.
No telehealth visit for the initial first visit.
Okay. And sometimes, Carrie, we see the word physician or authorized health or qualified health professional. That means like nurse practitioner, right? It doesn't mean MA or RN in this case.
Correct.
Okay.
That's generally referring to a physician, nurse practitioner, or physician assistant. So look, this code set, step in the right direction for sure. We had pointed out previously that RPM kind of leaves out pain when you're talking about a physiologic metric, because it's and it can't be with RPM, it can't be self-reported. And boy, that's generally how you report pain, right? You self-report it. So great that they've put this code set out here. It's a little wonky. It's listed in the telehealth set of codes, even though the first visit may not be done by telehealth. The good news is that following visits can be done virtually by telehealth, even by just audio only. So that is good news. The barrier really is going to be the requirement that the physician or practitioner sort of provide these services directly.
And it is one of those, you must get 30 minutes. It's not one of those, I got 22, I'm rounding up. It's
correct.
30 minutes or more. So you have to track the time, you have to log it, and very provider heavy, being that the physician is involved. And it actually, in both codes, the physician is involved, both the 30 minutes and then the G3003, the additional 15 minutes, that's a provider-based code as well.
That's correct. And I think, where we'd like to get is to the point where clinical staff could be involved as well in providing those services and take some of the burden directly off the practitioner or the physician.
Yeah. And like we talked about with RTM, when it came out, it was initially direct supervision required. So this is one of those same things, a third-party group. And I know we have a lot of them on the call today. Unfortunately, you're not able to provide this service. For the clinics on the call today, you as the provider would have to provide not only in-house, but do the work, or a nurse practitioner or someone provider level. And I thought this was interesting, Carrie. $79 for a provider's use of 30 minutes. So I'm not a doctor or a mathematician, but if I was a doctor on today's call, I'm thinking to myself, I could do 2 E&Ms during that same 30 minutes, make a heck of a lot more, or I can enroll this patient in chronic care management, assuming they have 2 chronic conditions, chronic pain being one, and my medical assistant or my RN can spend 20 minutes and make almost as much. What would you say if someone is thinking that? Is that how we're reading this, Carrie?
I certainly think it's a reasonable, logical exercise to go through, right? I mean, you're exactly right, Dan. I mean, this is, in effect, certainly the first visit is an in-person visit with the practitioner. Another visit, whether it's by telehealth or not, still is the length of time, right? Of a visit, in effect, that a practitioner could be spending their time, a physician, a nurse practitioner, a PA. I do believe that the lift is going to come for the practitioners when clinical staff can participate in this a bit. And the mechanism for clinical staff to participate right now, you're right, Dan, is sort of the chronic care management services. It's hard to understand why, when we agree that chronic pain is a chronic condition, one might not use either chronic care management or principal care management codes to get at a similar impact and result for the patient, while utilizing lower level staff that are going to be escalating up to the practitioner. So, your logic is spot on, and hopefully we'll get these kind of improved.
Yeah. So it might take a couple of years, but for those of you who still want to do it, this is one program that you can do with others. So you can do CCM and CPM in the same month. Remember, we said you couldn't do RTM and RPM, but this program, at least that is an advantage for those who do want to dive into this in 2023.
That's right.
For CPM, I agree with you, Carrie, that this is a good first step, and we love seeing steps in the right directions. I think allowing clinical staff to do CPM would be great. It's very provider intensive at a rate that's not really equal to the amount of time that a provider would spend. And unfortunately, I think providers are going to look at this and say, I could do something else. So for CPM to be a great program, I think for me, Carrie, it's allowing the clinical staff to do it, make it general supervision, and align the reimbursements, I think, better with the quality of work that's being done. Would you agree with that one? Definitely, yeah.
If you'd like to learn more about what to expect in 23 or other changes to these programs, check out our Learning Center. There's links in the description below. If you found this video helpful, don't forget to like it below or subscribe. Thanks for watching.